For talk number 6, we're just going to go over some of the common postoperative complications. And we're going to start with surgical complications first and move on to medical ones. And some of these we've already talked about. And so the first of those the surgical complications is bradyarrhythmias. We just talked about this in the last talk. These are due to damaged conduction system that generally recovers over time. And we're going to keep going. Bleeding, surgical bleeding, we already talked about in the shock talk number 3. And the most common sites that I've seen this happen are the rema, intercostal vessels, cannulation sites, and the saphenous vein grafts if it's a cabbage. Next is tamponade. We've also already addressed this. The most important thing to know for the CTICU patients is that tamponade for them is usually due to a localized fluid collection pushing on the right side of the heart. It is not a circumferential fluid collection around the heart, and this is because the pericardium is gone. So when you look for tamponade, just keep that in mind. Next is pneumothorax. My rule of thumb is that pneumothorax is very common, but it's very rarely clinically important. So this is especially important to know because not all pneumothoraxes need to be chased. In fact, 99% of them don't. Surgical chests are very different from medical chests, so we don't really want to put new chest tubes in these patients willy-nilly. So I think out of all the post-op patients that I've seen, I have only seen an instance of one clinically significant post-operative pneumothorax. So just keep that in mind. And this one was in residency, and we just kept the patient on 60% FiO2 overnight, and he was in a apical chest tube was placed the following morning, and he was extubated fine. So it's very rarely an emergency. And that goes counter to hemothorax, which is almost always an emergency. A lot of blood can drain into the chest in a short period of time. So if you see any evidence of a pneumothorax, increased pressure requirement, drop in hemoglobin, void out on chest x-ray, this needs to be investigated aggressively. It only takes a couple hours of a big pneumothorax for a patient to code. And so next we'll talk about surgery-specific complications. So for cabbages, what we're really concerned about post-op is graft failure. So one thing that we'll do for them is we'll get regular EKGs, usually every 12 hours. And the problem is that 99% of patients will have an abnormal EKG, and it's almost never clinically significant. However, if you have an abnormal EKG with hypotension, escalating inotropes, and a cardiogenic shock, then you can make the argument for graft failure. And this abnormal EKG occurs due to surgical manipulation of the heart, different perfusion of the heart, all kinds of things. So it's something to keep in mind, but just keep the patient's clinical status first, and then the EKG second. Septal myectomies, you tend to see damaged conduction systems, and this is no surprise because the bundle of His and the AV node are in the interventricular septum. So if like a piece of that conduction system gets wedged out, you're going to have issues. And then next we'll talk about valves. So I listed some general complications first. Now these are extremely rare, but they are all things that need to be bumped up to the surgeons immediately and might need the OR for correction within 24 hours. These are if the new valve is rocking, if there's a significant perivalvular leak, and if there's a new iatrogenic stenosis. And so again, these are very, very rare. But if a patient is hypotensive, if they're on all these inotropes and pressors, and they can't seem to settle out, throw an ultrasound on their heart, see if you can see any of these things. And some other more valve-specific issues, AVRs tend to get a conduction system damage and hypertension. These were already addressed in Talk 1. That mitral valve repair tend to see systolic anterior motion of the mitral valve. And then lastly, we'll take a few minutes to talk about AV valve replacement. So usually when you repair or when you replace a mitral or a tricuspid valve, the corresponding ventricle does just fine. That being said, the ventricles that fail tend to be decompensated going into a surgery. The reason why they're getting surgery is because the lesion was discovered very late in the course, or because the patient has been refractory to medical therapy. So these sick ventricles going into surgery tend to fail post-op, and we can kind of go in. That's a whole other talk of why that happens. Perhaps that could be a talk for later time. But just know that whenever decompensated ventricles go into surgery and there's severe MR or TR, and you fix the valve, those ventricles are at high risk for failing post-op. And sometimes it takes only 12 hours for them to end up on VA ECMO. And so just keep that in mind. And we can't blame our surgeons for everything. So we'll look at medical complications next. And so the first of which are neurologic. I think differentiating between delirium and strokes is a huge thing we see in the ICU. Because again, just like some of these, I think the theme here is when you have altered mental status in the CTICU, 99% of the time it's a delirium, and it's harmless. It's not good, and we try to minimize it, but the patient's not going to die. And that being said, if there's a focal deficit, or it definitely needs to be escalated to neuro ICU, stroke, CT head, in serial exams. So that was what I'll say is most altered mental status is not stroke, but when you miss a stroke, there's huge consequences. So I differentiate between focal and a non-focal neuro exam, and that will get you out of trouble 99.99% of the time. And some pulmonary complications. We see a lot of pulmonary edema in these post-op patients, and that's because they go into the OR, have cardiopulmonary bypass, they have post-op vasoplegic shock, and we load them up with blood products and fluids, and then once that vasoplegic shock wears off, suddenly they can be up to 5 to 10 liters volume overloaded. So on post-op day 1, they kind of loaded up with all this volume, and then post-op day 2 through 5, we have to diurese it all off. So we tend to see a lot of pulmonary edema. It can be tenuous extubations, reintubations. So just something to keep in mind. This is kind of a unique thing to CT surgery patients who undergo cardiopulmonary bypass. The second most common pulmonary complication that we see is mucus plugging, and this is kind of have this perfect storm of older deconditioned patients who can't clear their secretions. They're probably sedated, might be delirious, and were recently intubated or recently extubated. So we try to do our best to get their secretions cleared. We do NT suctioning, nebulizers, inspiratory spirometry, chest physiotherapy, early mobilization. Sometimes it's just not enough, and so for that we have to do bronchoscopy to suck out everything. And the second to last thing we'll talk about is renal failure. And CT surgery patients are at a higher risk of this because they have fewer nephrons to start with. Almost all these patients start with CKD3. So if you have an AKI and you have fewer nephrons available, you are at higher risk of going to acute renal failure. And this is because of three main reasons. Reason number one, patients are in both. Patients can have 3 to 5 different types of shock after surgery, so they're going to have a lower MAP. And number two, they tend to have a higher venous or a higher central venous pressure due to volume overload, especially on post-op day 1 through 5. And as we know, in order to perfuse a tissue bed, the perfusion pressure is MAP minus CVP. So this combinations tends to give lower than average MAPs and higher than average CVPs. So it's not good for the kidneys. And then thirdly, the pressors and inotropes can cause vasoconstriction of all the blood vessels in the body, which can also decrease blood flow. And the last thing that I'll talk about is that with a renal failure, is that it tends to be harder to diurese these patients because their GFRs are already low, and then when they have an AKI, they go even lower. And if you recall from second year medical school, that diuretics need to be secreted into the collecting tubule in order to act. So if your GFR is already low, it's going to be harder to diurese a patient. It's kind of this downward spiral. As the more volume overloaded that you get, the harder you are to diurese. So something to keep in mind. That's why it's very good to get ahead of this and stay on top of their volume status. And the last complication that we'll talk about is hypoglycemia, and this happens usually due to epinephrine drips, and especially if the patient is diabetic at baseline. So usually not an issue. There's been multiple studies showing insulin drips are superior to sliding scale insulin and improve outcomes. So these patients end up on insulin drips usually until post-op day 2 or 3. They can get weaned off once the inotropes are weaned, and usually not an issue.